c'est un syndrome physiologique caractérisé par une diminution de la réserve et de la résistance aux facteurs de stress, résultant d'un déclin cumulatif dans plusieurs systèmes physiologiques. Cela entraîne une vulnérabilité à des conséquences indésirables. If we think about the concept of responding to stress, this illustration helps to understand how people respond to stress when they are frail, mildly frail, severely frail, or managing well. At the top, we have in green, en vert, people who are older but are managing well. They are not frail, and they have a stressor, such as an illness, an injury, chirurgie, chemotherapy, but they are able to respond with a short decline in function and then back to normal. In people who have mild frailty, in the middle, who are on orange, the response to stress is harder for their body, their function decreases, but they are able to respond. But the response takes longer and is incomplete. Finally, when one looks at the severe frail at the bottom, en rouge, these people respond to stress and the response leads to becoming dependent in function, and the recovery is much, much slower and even more incomplete. And so people remain more permanently dependent with a higher risk of multiple bad outcomes. Okay. I'm trying to be brief in each section, but happy to take questions after. Second thing I will talk about is measuring frailty, mesurer la fragilité. There is no universally accepted approach to measurement of frailty, but there are some very common approaches, and I will briefly highlight 3 of them that are common in the broader geriatric literature. And then a little later, we will talk about the G8, which is common in oncology. So the most common frailty definition is one by Linda Fried and colleagues from les États-Unis. And it includes 5 components: perte de poids, épuisement autodéclaré, les faibles dépenses énergétiques or decreased energy expenditure, vitesse de marche lente or slow gait speed, et faible force de préhension. And if you have none of these, you are considered non-frail. If you have 1 or 2, you are pre-frail, in other words, higher risk of frailty. And if you have 3 or 4 or 5 of these elements, you are considered frail. This is one definition. Another very common definition that you will see in the literature is the cumulative deficit model by a Canadian, Dr. Ken Rockwood. And this is from the Canadian Study of Health and Aging, which was a 5-year prospective cohort study with over 10,000 people, an âge moyen 82. They had 92 baseline variables that they included in their model to create a frailty index. These included symptoms such as fatigue or pain, signs on the physical exam, laboratory abnormalities, comorbidities, and various disabilities. And from that, they created this frailty index, which is simply a ratio of all the abnormal variables divided by the total number of variables. It is, in essence, a fraction on a scale of 0 to 1. And the higher the score, the more frail a person is. And virtually no one has a score above 0.6, because that is near death. And there have been several hundred studies that have shown that as the frailty index score goes up, we have more bad outcomes. This has been shown in mice, in flies, in other mammals, and many, many studies in humans. Finally, the same group, Rockwood and colleagues out of La Nouvelle-Écosse in Canada, have created this clinical frailty scale, which is a very simplified version of the more complex cumulative deficit model I just described. It is a single item based on a picture that has 9 options. And the higher your score, the greater your frailty. I will show you the picture in a moment. It is traduit en français, and it is easy to teach les cliniciens, and it can be scored after a routine clinical encounter with a patient. So this is the score de fragilité clinique, and you will see, par exemple, for those who have a score of 1, they are well, they are not frail or pre-frail, they are robust, they're active, énergique, motivés. These people are actively exercising, and they look well and fit for their age. On the other end of the spectrum, we have, for example, a score of 9 en phase terminale. These individuals are approaching death. It consists of people who have an espérance de vie moins que 6 mois, and these people are fragile or frail, and it is obvious. And in between, we have increasing degrees of frailty. Most studies will define frailty beginning at a score of 5 or higher. The clinical frailty scale predicts death in this one survival analysis that goes out for almost 7 years, 6+ years. You will see that people in the blue bar with a score of 1 to 3 who are well have a low mortality, and this is in the broader population of older adults. They do not necessarily have cancer. People who are vulnerable with a score of 4 or 5 have a worse survival, and as one becomes more frail, the likelihood of death goes up. So a very clear survival separation between different levels of frailty on this one single item that you can score in only 5 minutes after meeting with a patient. Quite easy to teach. Okay, what is the relevance of frailty to prostate cancer? And there are multiple articles that have talked about this. I have highlighted 2 here that talk about frailty and cancer more broadly. I will make just a couple of points here, and then I will focus on frailty in surgery, in radiation and chemotherapy specifically. But frailty becomes more common in men with prostate cancer as they become older. Frailty is associated with worse outcomes after surgery. There is a greater risk of dying from non-cancer causes. There is greater toxicity with chemotherapy. And people who are treated with androgen deprivation or chemotherapy have an acceleration of their frailty. And I will describe these in a moment. Let's talk a little bit about the screening and diagnosis of frailty, dépistage et diagnostic. In terms of screening, there is no strong evidence that systematic screening of everyone coming into an oncology clinic or a geriatric clinic is helpful at this point in time. There's no large, high-quality randomized trials. In theory, if you can screen for frailty and pick it up early, you may be able to do targeted prevention or provide extra supportive care. And in the cancer setting, it may influence the decision-making around cancer. There are several popular tools that have been used in the cancer setting to detect frailty. The G8 is the most common. There is also the Vulnerable Elders Survey and the Frail tool. I will talk a little bit about the G8. The G8 is advocated by the EAU, ESTRO, and CIOG, the Société Internationale d'Oncologie Gériatrique, in their guidelines for prostate cancer. And they recommend using the G8 to screen older adults with prostate cancer for frailty. The G8 was developed from a nutritional tool called the Mini Nutritional Assessment to try and detect vulnerability in older adults with cancer, particularly those who are considering chemotherapy. The G8 takes 4 to 5 minutes and needs a health professional, but that health professional does not have to be a physician. And it has high sensitivity, 77 to 90%, of picking up people who would benefit from a full geriatric assessment or who are frail, but the specificity is more moderate in the 60 to 75% range, with a score of 14 or lower being considered abnormal. There are 8 items in the G8, and in English on the left and en français on à la droite. The questions include decreased intake of food, weight loss, mobility, troubles neuropsychiatriques, the body mass index, taking more than 3 médicaments chaque jour, self-rated health, and an item on age. And each of these gets a certain number of points. As I said, it can be done in 4 or 5 minutes. It is easy to do. There are now 2 versions of the G8 that people can do on their own, but they have not been extensively validated. I'm going to give an example of one study that looked at screening for frailty in a surgical setting. This was not in prostate cancer. In fact, it was not only in cancer. It was over 9,000 patients undergoing 12 different types of surgery for cancer and non-cancer causes. And they had a preoperative frailty screening with a different tool called the Risk Analysis Index. Takes less than 10 minutes. And people with a score of 21 or higher were identified, and they underwent a careful surgical review and discussion with anesthesia, with les soins intensifs, les soins palliatifs, and depending on each case. And what they found, and this was not a randomized trial, but a before-after analysis, an analyse avant-après, and what they found was the 30-day mortality decreased in people from 12% down to 3.8% when they used this tool and had a careful discussion and modified surgery, modified anesthesia, or sometimes did not even offer surgery. And these findings are interesting because they suggest that a greater awareness of frailty allows clinicians to adapt treatment and offer different types of co-management and enhanced supportive care that may help patients and reduce important outcomes like mortality. However, this study is limited. It is not a randomized trial. There were changes over time, even in people who did not undergo screening, suggesting that all the effects were not just due to screening. They did not standardize the interventions that they did in someone who screened positive, and there were significant amounts of missing data. But with 9,000 patients, it does raise the possibility that systematic screening for frailty, at least in surgery, may improve outcomes. Obviously, we want more studies, and we want more studies in prostate cancer. Let's talk now about traitement et cogestion. I put up pictures of some of the various medicaments which are advertised in Canada and the United States that people can buy over the counter as a magical way, comment ça veut dire en français, magique, médicament magique, that will reverse aging. And we know that people spend billions of dollars, I'm sure it's the same en France, unfortunately looking for these magical tablets to reverse aging and fragilité. Unfortunately, there are very few such tablets, and I would like to find them so I can start taking them myself. This slide gives you an example of a concept. And the concept, je suis désolé because I cannot translate this easily into French. But the idea is that people may move from one state to another. People who are not frail may stay non-frail, or if they are subjected to chirurgie or radiation or chemotherapy, then they may become pre-frail or frail, or they may die, but they may move back and forth. People who are frail may become pre-frail or go from pre-frail to non-frail. And this is a dynamic transition, at least in theory. So I'm going to start with more general comments, and then I will focus on prostate surgery, radiation, and systemic therapy. Can we prevent frailty? So the Cochrane database does high-quality systematic reviews of the literature, and they have done multiple reviews in geriatric assessment, not only of frail people, but the idea is that geriatric assessment is the best way to identify frailty. And they included 29 randomized control trials with almost 14,000 patients who underwent either geriatric assessment and management or usual care, mostly hospitalized. And what they found was that in the meta-analysis, people who had a geriatric assessment were more likely to be alive and in their own homes at 3 months and 6 months. They were less likely to be institutionalized, and they were less likely to die or have deterioration in function. These were statistically significant, clinically important reductions in bad outcomes. But this was not oncology, and it was not prostate cancer. In the cancer setting, there are 3 main approaches, 3 approches principales de la fragilité dans les contextes de cancer. Numéro 1, c'est modifier le traitement du cancer. I will talk more about that. The second option is gérer la fragilité et les conditions associées pour réduire les complications. I will talk about that. Finally, essayer de renverser la fragilité. I will talk very briefly about this because we do not have much data yet at all for that third option. Alors, let's talk about surgery first. There are 3 clinical studies that have been published in patients undergoing radical prostatectomy or multiple genitourinary surgical procedures, including radical prostatectomy, that have looked at frailty and the association with outcomes. At least 3 that I have found and were identified in a systematic review by Shaw and colleagues. What they have found, in summary, is that over time, we are seeing more older adults, age 65 and older, who are undergoing radical prostatectomy who are frail. This is before their surgery. They are detected to be frail, upwards of 10 to 20% in at least one of those studies. What has also been shown very clearly is that frailty is associated with higher rates of complications, all complications, major complications, discharge somewhere other than home, in other words, nursing home, rehabilitation. They have higher costs in hospital and excess mortality. The odds of a major complication are increased if you are frail 3 to 4 times, and the likelihood of dying within 30 days is increased up to 6 times. Now, we know that the risk of death with radical prostatectomy in general is under 1%, but a 6-fold increase is significant. Which particular elements of frailty are associated with these risks is not very clear right now. We also know, but this is based on very limited data, that surgery may increase subsequent frailty in people who are not frail by 10 to 20%, but the data here are quite limited. If we go to the 2020 guidelines from the EAU, the EANM, ESTRO, and CIOG, they recommend that every older adult considering surgery for early stage prostate cancer should undergo the G8 or the G8, as well as the mini-COG, which is a 2-item cognitive screen. And I believe that there was a little earlier discussion in your conference about the mini-COG. So I will not go over it in detail, but I can talk about it in the question period. But if you score normal, so a score of more than 14, then nothing further needs to be done. These people are fit à gauche. If you have a score of 14 or lower, the recommendation from the guideline is that a full geriatric assessment should be done, particularly focusing on the activities of daily living, the weight loss, and comorbidities. And if you have a few of these abnormalities, you are considered vulnerable. And if you are considered frail, if you have more abnormalities in activities of daily living or weight loss or significant comorbidity, and you should be considered for further assessment and geriatric intervention or cogestion. But they don't give you more details in that guideline. We really do not have high quality intervention studies in the setting of surgery for prostate cancer. We have some data in other oncologic surgery. We have indirect evidence of a couple of key things that are important. The first is that we should do a formal life expectancy estimate in all older adults. I believe this was presented earlier today in the conference with tools like e-prognosis and others that allow you to estimate the remaining life independent of cancer. We should definitely think about considering less intensive treatment for people who are pre-frail or mildly frail. And if you have moderate frailty, some of these individuals may be better managed with active surveillance or supportive care. We know that in the prostate cancer setting, for most of these men over 65, particularly over 70, there is very little data that surgery is associated with better survival than radiation, for example. And radiation is better tolerated in people who have mild frailty. If you have moderate frailty, you are probably not even benefiting from radiation because the risk of death is much higher from other causes. If you still are going to go ahead with surgery and you have had a good discussion with the patient, then several strategies have been shown, not in radical prostatectomy particularly, but in other genitourinary malignancies and other surgical procedures in cancer to reduce the bad outcomes. This includes laparoscopic techniques as opposed to open surgery, carefully monitoring the depth of anesthesia to reduce the risk of delirium, careful attention to nutrition, careful assessment of comorbidities and medications, in particular, les comorbidités cardiaques ou les accidents vasculaires cérébrales. These are associated with the highest risk of surgical outcomes, such as myocardial infarction, stroke, and 30-day mortality. We have multiple strategies that can reduce the risk of delirium by 30%, and frail individuals are higher risk of delirium. We have evidence for préhabilitation and the concept of the early recovery after surgery protocol. I don't know the abbreviation en français, mais récupération précoce après une chirurgie. And of course, really think about cogestion gériatrique pour les patients who are considering chirurgie once they are admitted to hospital, because that has been shown to reduce multiple bad outcomes. In the setting of radiation, the efficacy of radiation is no different in people who are frail compared to those who are fit. However, frail individuals have a higher risk of dying from non-cancer causes. So in early stage prostate cancer, the benefits of radiation become much less, whereas in palliative radiation for managing painful metastasis, it is still an excellent strategy with very limited side effects in people who are frail. We have very little data on whether radiation toxicity goes up with frailty, but there was one study that I could find that suggested that if people are treated with radiation across multiple tumors that are treated curatively, the risk of grade 3 toxicity goes up approximately 7%, the absolute risk. However, the sample size was small and the 7% increase was not statistically significant. Nevertheless, there may be an increased risk and it makes sense. Still, Radiation is generally very well tolerated in people who are frail, in my experience and from the limited literature we have. Whether radiation increases frailty is really not well known. There is one study that I have found published in the Journal of Geriatric Oncology from the United States that suggested there was a higher risk of functional decline after radiation. But this study did not focus only on people who are frail. So we do not know if people who are frail were higher risk, but it makes sense when you consider the total evidence and the understanding of the physiology of frailty. So likely there is a small increased risk of functional decline with frailty in the setting of radiation, curative radiation, but the data are limited. Okay, on to systemic therapy, and I hope I'm not going too quickly, but androgen deprivation therapy, particularly in older men, has been suggested to accelerate frailty in 2 different studies. The measurements of frailty and the time period were limited and the sample sizes were small, but there is some suggestion that androgen deprivation accelerates frailty. Whether intermittent treatment is better than continuous treatment with androgen deprivation is currently unclear. I have found no good data. In terms of chemotherapy, we have a lot more data. We have multiple studies that have shown across various cancers that chemotherapy toxicity goes up with frailty. There is no question, no uncertainty. I know that earlier today in the conference, there was a presentation about chemotherapy toxicity prediction tools, and I believe they discussed the CARG tool as well as the CRASH tool. I will not go into them in any detail, but these tools incorporate frailty, but they do not look at frailty directly. They look at elements of frailty that are associated with increased risk. But they do allow us to stratify patients better who have a higher risk of severe side effects. We know from other studies that the elements or the composants de fragilité, which are associated most consistently with an increased risk of toxicity, are poor functional status or dependence in one or more instrumental activities of daily living, the déficience cognitive, malnutrition, et polypharmacie. These 4 elements are the most consistently associated with higher toxicity. But other elements such as depression and social vulnerability may be, but the data are not so clear. I have published, I believe, the only study so far that has directly validated the CARG tool for chemotherapy toxicity with docetaxel in the setting of metastatic prostate cancer, particularly castrate-resistant prostate cancer. And on the left, you can see people who are low risk have a 36% risk of grade 3 or more toxicity. People who are intermediate risk have a 67%, and people who are high risk have a greater than 90% risk of severe toxicity with full dose chemotherapy. So docetaxel 75 milligrams per meter squared every 3 weeks. And so I believe this is increasing evidence that the CARG tool is valuable for medical oncologists in the setting of prostate cancer. If you are unaware, on the right, we also showed that the tool can differentiate people who are low, intermediate, and high risk of severe toxicity from ARATs, such as abiraterone and enzalutamide. But this is the first time this has been shown. It has not been independently validated here, but still, I think, interesting. So in general, in the setting of cancer therapies, we know that older adults who undergo chemotherapy will on average have a decline in functional status during treatment. On average, 20 to 40% of people will have a decline in one or more basic or instrumental activities of daily living. In other words, they will go from being independent in shopping to needing assistance, or independent in bathing to becoming dependent on bathing, for example, during chemotherapy. And this is important when counseling your patients. Importantly, when chemotherapy finishes, 50% or more, 50 to 70% of people will eventually regain their baseline function. However, it is less likely to return to baseline if the treatment was in a palliative setting, which of course it often is with chemotherapy, especially with metastatic disease, or if you had baseline functional impairment, which most people with frailty do. Therefore, people who are frail are more likely to have decline in function and less likely to recover. In the setting of prostate cancer, there are 3 studies that I have found that are interesting, and I will highlight them very briefly and can discuss them further in the question period. One study suggested sarcopenia, not frailty, but they looked at sarcopenia, which is very common with frailty, was associated with poorer tolerance of docetaxel in advanced prostate cancer. I apologize, this slide was not translated into French. I missed that. Another study suggested that of the various variables they looked at, comorbidité, médicaments, etc., they only found that the G8, the G8 score, was associated with early treatment stopping because of toxicity. Our group looked at whether frailty was associated with worse outcomes in an observational study in men undergoing either docetaxel or an ERAT for MCRPC. We used 3 different measures of frailty: the Rockwood Frailty Index, the G8, and the Vulnerable Elder Survey. And we found we had only 30 men with frailty, 65 who were pre-frail, and 80 who were non-frail. But unfortunately, the numbers were limited, so we could not separate chemotherapy from an ERAT. What we did find was a couple of key things. Physical function was worse in frail men. This is not a surprise, even before they started treatment, and it remained stable. For example, grip strength on the top remained stable over 6 months with treatment, or it worsened slightly, such as gait speed in frail, but did not worsen in the pre-frail or the non-frail. So it seems that physical functioning gets worse in people who are frail and is worse to begin with, which is not surprising. However, interestingly, quality of life, so the non-frail are in gray, their quality of life was stable to improved on the FACT-G in comparison to the pre-frail and the non-frail, and their fatigue level actually reduced. However, the study was substantially limited because of the small number of patients and missing data. But it does suggest that some carefully selected men who have mild frailty, particularly if the frailty may be due to symptomatic, advanced, or high-burden metastatic prostate cancer, they may benefit and tolerate therapies such as ERATs and chemotherapy, but a substantial number of these patients will have to stop treatment early, and many of them will have worsening physical function. But they may be willing to undergo treatment to improve quality of life and possibly improve survival. But we do not know how much the survival is improved because we have very little data. And geriatric assessment is helpful in understanding and optimizing these patients avec cogestion, par exemple. So how do we manage frailty in the setting of systemic therapy? I'm wrapping up here. So there are very few high-quality intervention studies, especially in the setting of prostate cancer. We have indirect evidence from other settings. So we know that, or we strongly suggest based on expert opinion and non-randomized studies, that individuals who are pre-frail or frail should consider an upfront dose reduction of at least 15 to 25%. They should be avoiding doublet therapy and should be looking at single agent therapy. And they should be considering regimens such as the weekly or 2-weekly regimens rather than the conventional 3-weekly regimen if you are going to consider docetaxel or cabazitaxel. Sometimes they may benefit from an ERAT instead of chemotherapy. I think most of you would be giving ERATs rather than chemotherapy anyways, or considering a radiopharmaceutical such as radium or lutetium. And some of these individuals, depending how frail they are and the risk of toxicity, the recommendation would be no chemotherapy, and that really we should be focusing on supportive care. I will highlight, since I know this has been presented earlier, the geriatric assessment and co-management on the basis of 3 high-quality randomized controlled trials has been associated with a reduction in severe toxicity by 10 to 20%, associated with improvement in quality of life and reduced hospitalization. The last thing I will say is that reversing frailty has been attempted, but the data are very limited. There are some data in oncology, not in prostate particularly, but in oncology settings, that exercise programs, intensive exercise programs with both aerobic and particularly resistance training or muscle building, with or without nutritional support, is associated with a prevention of frailty or a reversal of frailty in maybe 10 or 20%. But these are small trials. There are several experimental approaches, such as using ghrelin mimetics like anamorelin, or a type 2 activin receptor monoclonal antibody like bimagrumab, as well as some very preliminary data with human allogeneic mesenchymal stem cells. But none of these studies are in the prostate cancer setting, so we have a lot more to learn. Le résumé, so la fragilité est courante avec les vieillissements, mais pas universelle. La fragilité est associée à un mauvais prognostic et à des multiples effets indésirables en oncologie. Les preuves sont les plus solides dans les contextes de chirurgie et de chimiothérapie. We know less about radiation. Chez les patients pré-fragiles ou fragiles, examinez si le traitement proposé est approprié. Faut-il réduire l'intensité du traitement? Calculer le risque à l'aide d'une utile validité. For example, the CARG tool and e-prognosis. Et finalement, obtenir une évaluation gériatrique et envisager une cogestion. I would like to acknowledge some of my colleagues who have given me information on frailty in general context. I want to say thank you, merci beaucoup à Google Translate, Dr. Farid Medleg, who assisted me avec traduction, et merci beaucoup.